Good day. My name is Gerald Holtmann. I'm a professor of medicine at the University of Queensland and the director of the Department of Gastroenterology and Hepatology at the Princess Alexandra Hospital here in Queensland, Australia.
Hi, I'm Naomi Moy and I'm a researcher at Queensland University of Technology here in Queensland, Australia, as well as I'm a researcher here at the Department of Gastroenterology and Hepatology at the Princess Alexandra Hospital here in Brisbane. And today we will be providing additional information on our recently published paper called the Risk-Based Decision Making Related to Preprocedural Testing for COVID-19 in the Setting of Gastrointestinal Endoscopy.
The COVID pandemic presented many challenges to all of us. It impacted service delivery, it endangered our patients by delaying services, and clearly it exposed staff to the risk of COVID infections. Now, many of us are vaccinated. We are now in an endemic phase, and we still have infections in our communities, but the transmission rates are rapidly changing. Most staff members are well protected, and we do have measures to prevent transmission, but there is a significant residual risk. Measures to reduce this risk include testing of patients who are referred for procedures. However, testing strategies, when to do the testing and when to stop testing, are currently not determined by available evidence.
Part of our research was to examine or provide further discussion about how people perceive information and how this information can be used to make further decisions. So what I mean by this is how our potential belief systems or our biases could have influenced our decisions around pre-procedural testing at both an individual level and at the governance level.
Clinically, we are frequently inclined to choose the most safe approach, but a very safe approach might not be feasible and it might not be cost effective. And for us, the question was, what type of testing should be used, when to start, when to finish, or in other words, when is the benefit of testing not justifiable based upon the cost which is required to test every patient who is referred for an endoscopic procedure.
Part of this discussion around costs also involves a discussion around the opportunity costs. So as we're referring to when the benefit no longer exceeds the costs. So for us, we would like to consider things about whether you test someone or not before a procedure and who you wouldn't be able to test as a result of testing those other patients. Or whether or not, if you're not testing, how this might affect the workforce. So these are things that will come in together to impact your decisions. However, when it comes to things that are risk-based, there is something known as probability neglect, which can influence your decisions about how you will move going forward. In the case of probability neglect, if you perceive something as higher risk than the actual probability of that risk occurring, you're unlikely to make an optimal decision. We propose a tool that factors in potential information that could link to a serious adverse event in a healthcare worker to provide more information about how to make decisions.
This tool, which is available online, and you will see the link here, can guide decisions based upon the costs associated with the avoidance of an adverse outcome of a healthcare worker who provides services. And we modeled this based upon a cohort of 1 million procedures provided, and we explored a variety of scenarios, and with this tool you can adjust it to your local setting. You can imputate what is your transmission rate, you can imputate what is your vaccination rate among your staff, and what are your local costs for a specific testing strategy. Why
did we vary these strategies? Well, we knew that in each case there are potential options that you as a decision maker or someone in the healthcare system might be facing. It is a complex system, and we have provided a simplification of potential strategies that are going forward. Now, these strategies come together to create a probability, which is then used to calculate the potential costs from each of your testing scenarios. Now, this involves rapid antigen testing or the polymerase chain reaction testing.
All this sounds very complicated. At the end of the day, the tool will calculate for you the costs per adverse outcome avoided. You can use your local data, and this is intended to help guide your local decision making. Please use common sense and clinical judgments when you apply these tools, but we hope that this risk-based decision modeling and the subsequent developed model and tool will help you to come to appropriate clinical decisions for your local facility. Thank you very much for your attention.
Thank you.